Welcome, everyone, and welcome to tonight's PEP Talk, Navigating Life After a Blood Clot Diagnosis. We are excited to have our clinical guest with us tonight, Diane Worth, who has been with us several times before and is a group favorite. So, Diane, thank you for joining us again for the new diagnosis PEP Talk. A little bit about Diane's background. She is a board-certified nurse practitioner and a true leader in the field of blood clot prevention, as well as in anticoagulation. She's also an esteemed member of the National Blood Clot Alliance Medical and Scientific Advisory Board and has been for quite some time. And throughout her career, she has been a pioneer in the VTE patient care space. So thank you for that, Diane. At Emory Healthcare, you manage clinics serving over 3,000 patients and launched a massive virtual clinic that empowered hundreds of people to test their own labs at home. And that was before virtual became a thing. So you were a thought leader in that as well. You helped build the award-winning heart failure program at Grady Memorial Hospital in Atlanta. Beyond the clinic, Diane is a national expert on thrombosis. She served on the board of directors for the National Certification Board for Anticoagulation Providers and worked alongside NBCA and the CDC to create the Stop the Clot educational curriculum, which has been taken by thousands and thousands of healthcare providers in this country. Whether she is publishing research or treating patients, Diane's mission is clear: better education for patients and providers is a winning solution. Diane, thanks again for joining us tonight. Just a couple of housekeeping things. It is Blood Clot Awareness Month. Yay! You'll probably have seen some information about our 100,000 challenge. We would love to have as many people as possible participate in that. It is to raise awareness and raise funds to raise awareness. So if you could join, we would absolutely love that. And we want to remind you that we are not here tonight to give medical advice. We are here for educational information only. So please, please, please make sure you talk to your own healthcare provider about your own special situation because everybody's unique and different. And again, we are not here to give you medical advice. With that, I'm going to turn it over to my PEP partner, say that 10 times fast, Todd Robertson, so he can kick off the polling questions.
I love BCAM, right? Strong enough to ask. That's our main
Absolutely.
tagline. Such a great tagline. Good evening, everyone. As soon as the poll questions pop up, if we can just get you to answer those, I'm going to read through them and then I'll read the responses. Here's our first one. I feel confident knowing what questions to ask my doctor after a blood clot diagnosis. Yes or no, or not sure. Our second question. I know at least 2 steps I can take to lower my risk of another blood clot. Yes, no, not sure. Our final question. I feel confident in my understanding my anticoagulant and anticoagulation treatment. Yes or no or not sure. So 3 quick questions, and we're going to get those results, and I'll read those to you before we get into the meat of our program. Love having this quarterly event because we have newly diagnosed patients coming into the support group all the time and just lots of questions. So it's great to have Diane here again to give us some answers.
Yeah, and we do this on a quarterly basis. So March, June, September, and December. Hopefully Diane will be with us all 4 of those times. But by all means, share this information with other patients and your family members, etc.
And this is no doubt one of our more popular pep talks. It's like,
Yeah.
it's awesome. So here are the results to the questions. Thanks, folks, for doing that. I feel confident knowing what questions to ask my doctor after a blood clot diagnosis. 26% said yes, but 29% said no, and 45% are not sure. So maybe that'll improve after tonight's episode. I know at least 2 steps I can take to lower my risk of another blood clot. 79% said yes, so that's good news.
Love that.
5% said no, 17% were not sure. And I feel confident in my understanding my anticoagulation treatment. 41% said yes, but 27% said no, and 30% or 32% said not sure. So interesting.
Okay, so we've got 59% on the anticoagulation side that, Diane, you're going to have to work your magic tonight discussing. Okay, so let's kick it off with understanding the diagnosis. Let's start at the very beginning of all of this because many of us, most of us probably did not get much of an explanation about our diagnosis. So what is venous blood clot? explain the difference to us between DVT, which is the deep vein thrombosis, and the pulmonary embolism in the lungs. And I know we've talked about this before, but why does it matter for patients if they're identified as provoked or unprovoked?
Okay, so thanks for having me again and welcome everyone, especially if you're new. I know this is a scary time in your life. And blood clots are very normal. Everybody forms blood clots. If you cut yourself, you form a scab, which is essentially a blood clot. They become problematic when they're in a blood vessel, though. So a blood clot in a venous uh, uh, capillary or a vein can become problematic when it blocks the blood flow and your tissue below it doesn't get good blood supply. It's a conglomeration of blood cells, platelets, and then it becomes fibrin. And when it blocks the blood flow, it can prevent blood going distal to that area, and you'll get pain and swelling. The problem becomes when it breaks loose and it moves. That's when you get a pulmonary embolism, and it can kill you if it hits your lung and it's a big enough one. That's why we worry about them. Uh, what was the second part of that question, Leslie? Sorry, I was focused
Um,
on.
the difference between DVT and PE.
Okay. So in the deep vein, we usually think of those usually in the distal legs or in the proximal legs, and the top or the bottom of your legs they form. But it's not uncommon for them to happen in the arms. And if they happen in other veins, sometimes we call those weird clots, like if they happen in your brain or in your abdomen and some of the blood vessels in your abdomen, like the portal vein. Those are odd clots, not common. Most common is going to be in your leg. And if it breaks loose, it's considered an embolism because it's moving. And if it lodges in one of the blood vessels in your lung, then it becomes a pulmonary embolism. So it's a clot that broke loose from someplace else. Very, very rarely do clots form in the blood vessels in the lungs. I would say maybe 1 out of 100 might have formed there. So 99% of them come from someplace else, either in the legs or arms or in your abdomen, and they travel up. And when the blood goes into circulation, it returns to the lungs first to drop off the carbon dioxide and pick up oxygen. And if it's a clot big enough, it lodges in the blood vessel. And that's when you may have chest pain and shortness of breath and start coughing up some bloody sputum. Those are the most common signs that we see patients present with, or they may have a high heart rate and a low oxygen saturation. Those are the most common signs.
Okay. So DVT typically in the large veins, usually the leg, but can be the abdomen, could be the arm. There are other locations that it could wind up in, but really the DVT is predominantly the leg and subsequently the arm. And then the PE is the piece that breaks off and goes into the lungs.
Correct.
Okay. And why does it matter? Because a lot of us are classified as either provoked or unprovoked. And I didn't know what unprovoked meant when I left the hospital. I had to look it up.
We tend to feel that unprovoked are a little bit more worrisome because we don't know why the patient formed a clot. So, provoked would be more someone that's had a recent surgery, recent trauma, an extended period of immobility, whether it be a long car ride or a transatlantic flight or transpacific flight where you're not moving around, sitting in the same position, and your blood pools and there's clotting factors in it. Unprovoked can be for a variety of reasons. You may have what we call a thrombophilia, which is something that you can inherit or you can acquire. It could be serious, like cancer, can be considered uh, something when you're unprovoked, but then they go looking and they find it, and then that would flip to provoked. But there may be clotting disorders that we don't know about. I mean, factor V Leiden has not been around that long, and it isn't necessarily a death sentence because 5% of the Caucasian population has factor V Leiden, but they don't all clot. But it was discovered right before I started doing thrombosis, which was in 2002. So it's not been around that long. So there may be other thrombophilias that we don't know about yet.
Okay. Quick question before we move on, because you mentioned travel. We've all kind of gotten conflicting data in terms of immobility, long car ride, long plane ride, sitting for a long period of time. What is the rule of thumb where you go into the danger zone?
So I've never had a clot, but I try and get up and walk every 1 hour on the plane, stop every 2 hours in a long car ride. Most important, I would say, would be staying adequately hydrated because I know when we get on an airplane, we don't want to have to bother the person next to us to get up to go to the bathroom. So we try not to drink a lot, but stay hydrated because dehydration is a risk factor for forming a clot. So if you get dehydrated, and there's not been clear-cut evidence that says the difference in the pressure in the cabins has anything to do with it. I do know that we don't advise patients traveling for 3 months after they have a new blood clot, but it's, I would say it's more the immobility and the dehydration. And we don't recommend drinking any alcoholic beverages or caffeinated beverages because those can be dehydrating as well.
Good point. Okay. Thank you for that. Todd?
Yeah, and hydration does two things, Diane, right? It number one, it keeps you hydrated, so it reduces the risk factor, but it also makes you get up to go to the bathroom, so you're
Correct.
moving. So especially on those long car rides, that gives you an opportunity to take those every 2 hour breaks, like you're talking about. After diagnosis, most patients are prescribed a blood thinner, better known as an anticoagulant. So I've got some questions for you. For those just starting their anticoagulant, I know some of them are confused on actually how it works, like does it really thin the blood, things like that. So tell us, how do anticoagulants work? How do clinicians decide which one they're going to prescribe to the patient and how often it should be taken? Why is it so important to take them consistently, to be adherent with that medication? And what are the risk factors for being on a blood thinner? Can someone stay on one long term also?
Okay, let's start for the last first. So you can stay on them indefinitely as long as your bleeding risk does not outweigh the risk of you staying on the clot, on the anticoagulant. Um, I, as professionals, we don't call them blood thinners, but for patients, I like the term blood thinner because it relates to what they think is happening. The medications do not actually change the viscosity or the thickness of your blood. What they do is they prolong the time it takes for you to form a clot. And it does this by inhibiting some of the clotting factors. The newer drugs like Eliquis and Xarelto, which aren't new anymore because they're almost in 15 years now, they block factor 10A. They're 10A inhibitors. So they slow it down. The goal is to slow it down, not totally prevent it. So while your body is constantly making clots all the time, everybody right now that's sitting there, they're making clots, but you also have proteins that dissolve clots. So you have protein C and protein S that dissolve clots. And then if you add a clot, an anticoagulant like Xarelto or Eliquis, those slow down the process for making clots. That's how they work. The doctor or the advanced practice provider that is treating you will decide, hopefully with some shared decision making, on which drug is best for you. Are you a once a day person or a twice a day person? The important thing is to remember to take them as prescribed every day. Don't try and ration your drugs out. These drugs are short lived. They're on quick, off quick. So the Xarelto you take once a day, Eliquis is twice a day. And if you miss a dose, you're taking a chance of being unprotected. So you miss 2 doses, and then, it's not like Coumadin that lasts, sometimes 5 days for it to get out of your system. These drugs are quick on, quick off. That's why there's less risk of life-threatening bleeding, is because they don't last as long as the warfarin, which was around for, 70 years before these new drugs came to market. And there's one more question, Todd. What was the other one that you asked about?
I actually think
Covered
you
them all?
yeah, you pretty much hit on it. But let me ask you, just as a quick follow up. So when you're on warfarin, you have to have your INR tested.
Correct.
On the newer, and I call them DOACs, direct oral anticoagulant, Xarelto, Eliquis. Do you have to have any blood tests, any blood work have to be done when you're on those?
We as clinicians, and at my clinic where I worked, I've recently retired. We recommend it at least every 6 months for the first year, and then at least annually. And what you're checking for is their renal function, because these drugs are cleared partially through the kidneys, and a CBC to make sure that there's not a slow leak somewhere where your hematocrit or your hemoglobin is drifting down. So those are the two main ones that we checked regularly where our patients were on the DOACs.
Okay, so just one last thing. For people that are on Xarelto, and I learned this before I moved to Eliquis, but on Xarelto, if you're on 15 or 20 milligrams, you have to have some food with the medication, from what I understand. Can you tell us what the reason for that is?
The bioavailability, if you take it on an empty stomach, is significantly less. So if you want to have 98% bioavailable, you want to take it with a meal. That's the 15 and the 20 milligram. The 10 milligram does not. So if you're on, if say you're 6 months out or a year out, and your doctor feels like it's safe for you to decrease your dose to the long-term dose for DVT prevention, then that dose does not need to be taken with food.
Okay,
Eliquis does not need to be taken with food.
excellent. Okay, I think we hit on all the questions and points.
Okay.
Leslie?
Well, actually, did we talk about how clinicians decide which one to prescribe?
So
Because
I said, that's the shared decision. Are you a once a day
Mhm.
or a twice a day? We look at your kidney function. And then some of it has to do around insurance. If you have a preferred drug plan that one may be on than the other. But basically, when I would talk to the patient, most of the drugs are on both plans now. It would be, are you a once a day or a twice a day? And can you remember to take it with food? Um, I often use the analogy of birth control being a once a day drug. How many women would be pregnant if you have to rely on someone of childbearing age to take the same medicine twice a day religiously to prevent pregnancy? So if you're someone that can't remember to take your medicine twice a day, especially if you're a younger childbearing age woman, then a once a day drug might be better for you.
yeah, okay. And just to follow up to Todd's question, so um, a lot of people are on the DOACs now. You're right; they're actually not that young anymore. They've been around for a while, but some people are still being prescribed other anticoagulants. When would that decision be made to have somebody on warfarin versus a DOAC, as an example?
For someone that has been diagnosed with antiphospholipid antibody syndrome, warfarin is still the best drug. The DOACs have not shown great results with that. So that's someone that has what we call APS diagnosis, or it may be someone that is pregnant and they are past week 6 to 12. They may go back on warfarin after week 12 until it's closer to delivery time. The other thing would be is if you can't afford the drugs. I mean, if you don't have insurance or your insurance copay is too high, sometimes patients opt for warfarin. The other option, the other patient population that we would use warfarin more in would be the end stage renal dialysis patients.
Mhm.
Warfarin, there's not been any good studies done on warfarin, but we've known that it's worked for 60 or 70 years in that patient population.
Right. Okay. And then just another follow-up question on the anticoagulation. So some of us have been on these for a very long time, and then all of a sudden they fail, and you get put on another DOAC or another. Why does that happen?
It's very rare. It's very rare. Typically, it
I'm
could
pointing at
be,
Todd.
like
I'm
Todd,
pointing
right?
at Todd.
Yeah, because Todd's been on. He's had 7 clots, I think, and
Mhm.
some of it is patient error that they miss doses and you're not protected when they're short lived.
Mhm.
Um, Other things that could happen if you're on another drug that could be an inducer or more of an inducer where some of the drugs that go through your liver can speed up the metabolism of your DOAC, and so you're not protected. That's why it's really important to have a good anticoagulation provider that stays up on what the drugs are that can be inducers or inhibitors of the CYP3/450 system. Is those are the things that happen. Sometimes we just don't know why they fail. And we've had patients that have done remarkably well for years, and then will pop up with another clot. Or the other concern I have when I have someone that's been religious, we know they take it every day and they clot again. Is there an underlying cause like a malignancy that the DOAC is not suppressing any longer?
Okay, thank you for that.
Yeah, I just wanted to mention that, I was on Xarelto starting in around 2012. That was in the beginning of when people started using Xarelto,
Mhm.
and was on it until a year and a half ago, and it always did really well. And I'm was very adherent with my medication. It's one thing that people just thought I was almost overly focused on, was not missing doses.
Right.
And we're not sure why that failed like that and why I got another DVT, but Eliquis has been doing very well. But I also think this is an opportunity for someone to make sure that they're their own advocate and following up with their medical provider team. Because when I was on warfarin, I also had a colonoscopy and was removed for several days as a homozygous factor V Leiden, and I clotted with a pulmonary embolism. So I was off a little bit too long. I wasn't bridged. So it was that kind of an error too. So I think we always have to make sure we're on the same page with our medical team too. I think that's important.
Well, and that's why it's so important to do these pep talks and hear from experts like Diane so that she can explain all of this. And then,
Hmm.
we really want people to know about the new patient guide that we have because that also goes through all of this information about anticoagulation. So if Taryn can put that, if she hasn't already, into the chat, that would be great. Speaking of the chat, we're getting some really excellent questions in the chat, and we're going to try to get to your questions. We're going to save some time at the end with Diane to go through some of these questions. But we're going to spend the next kind of 20 minutes or so going through some additional questions here. Okay, so I know you talked about INR a little bit earlier, but let's go to what doctors monitor in your blood. Okay, so you've been diagnosed, and then you kind of get shepherded along to, we're going to take a lot of blood from you. We're going to check a lot of things. So different labs from the time that you end up in the hospital or the emergency room to after the fact. What labs are commonly checked? INR, D-dimer, kidney function, platelet counts, and again, how do these all affect your treatments, your treatment after diagnosis or during and after diagnosis?
So you present to the ER, and one of the labs that's most is commonly drawn is the D-dimer, because the D-dimer is a byproduct of clots that are being chewed up by your protein C, protein S, which are your Miss Pac-Mans that go through the blood. So there's a certain level that is acceptable. I would say the high end of normal would be 300 in most labs, but when you present with a clot, you may have a D-dimer in the thousands. And so that's an easy blood test that if someone presents and you're like, okay, what's going on? Let me draw these labs, and the D-dimer presents high, then it sends the clinician down another pathway to get an ultrasound or maybe a chest CT to look for a pulmonary embolism. The CBC and the chemistry are drawn to make sure the patient's not severely anemic already, because you don't want to put someone with severe anemia on a anticoagulant. If they have a bleed, they don't have a reserve. And platelets make us very uncomfortable when they're less than 50,000. So a lot of our cancer patients do clot, but a lot of the chemo drugs also cause platelets to drop significantly down to like 10 or 15,000. So we have to weigh all that in when we're trying to decide how we're going to treat a patient that's newly diagnosed. So it's mainly a benchmark to look and see. Very rarely are other blood tests drawn to look for causes of clots on that initial presentation, because it's not going to change what we're going to do. If we decide you have a clot, we don't really care if you have factor V Leiden or prothrombin gene mutation. We're worried about keeping that clot from propagating and getting bigger and moving. So, and during the clotting phase is not the best time to check for thrombophilia. So it's better to do it down the line later if it needs to be done at all. If it's not going to change the course of what you're doing, then it's not recommended to check for thrombophilias.
Okay. And well, not a blood test, ultrasound. Why do they use ultrasound if they suspect a clot?
Well, to confirm it, number one, and to decide where the proximity is. So proximal clots are more worrisome. Distal clots, like below the calf or below the knee, will usually require to come back within a week to have another ultrasound done. Sometimes providers elect to not treat a distal clot. I was never comfortable not treating. If a patient presents with symptoms, how long does it take for that distal clot to propagate? So it's entirely up, but the guidelines do suggest that if it's a distal clot, that you repeat the ultrasound within 7 days to see if it's extended up into the proximal leg. And that's what you're looking mainly is ultrasounds of a lot of organizations will only do the proximal veins. But then if there's a distal clot, you don't know about it. So if there's no proximal clot, do you bring them back in a week? Well, and then what's the chance of that patient? Now, these patients that we have here are very invested in that, but not all patients you can count on to come back and have another ultrasound done in a week. So that's what you're looking for with the ultrasound is the confirmation to treat.
Okay, great. Todd?
Yeah, Diane, I want to ask you about some risk factors, but first, another big concern is reoccurrence. Could this happen again? So why is the risk higher in that first 30 days? Could you tell us that again? And what's the long-term risk of a second clot?
So the risk during that first 30 days is things are very revved up. Your clotting cascade has, for whatever reason, decided to form a clot. So it's going to take some time for your body to dissolve the clot. The anticoagulants or the blood thinners do not dissolve the clot. Your body has to do this. What they do is keep it from getting any bigger. So until you get things quieted down, you have lots of inflammatory markers that have gone up. Your CRP is probably elevated. And you have swelling, which may compress the vein even a little bit more, causing more constriction there for the blood flow. So during that first 30 days, it takes time for the body to dissolve that clot. The risk of reoccurrence is up to 30% by year 5. So if you stop your anticoagulation, about 30 of you out of 100 will have another clot. We used to think that that risk was only for unprovoked, but that's not true. So we know now that patients with even provoked clots still have that risk of reoccurrence. It's not as high. It's about 10% less. But, so long-term anticoagulation sometimes is a good solution for everybody.
Sure. Let's talk about risk factors real quick, because if we have one mode of self-defense that is very effective, it's risk factor management. That's what I've always preached. That's what I've always believed in. It's just then when we don't talk about blood clots early on, before we've had that first blood clot, we don't think about risk factors and we don't think about what causes a blood clot. But let's talk about things like some of the big ones like smoking, obesity, not having a healthy weight, immobility, certain medical conditions. And of course, we touched on this a little bit about family history of blood clots. Diane, why do those matter and how can people reduce their risks?
So thrombophilias that are inherited, especially like you said, you're homozygous. So not everyone's going to know that. So you get genes from both your mother and your father. And if you get a gene for a thrombophilia like factor V Leiden or prothrombin gene mutation, and you get both your parents are positive, and you get both of those genes, your risk is much higher for having a clot than someone that is heterozygous, meaning you only have one of the genes. So those are some of the familial risk factors, is if you have a known family history of thrombophilias, if you have first degree relatives that have clots, aunts, uncles, brothers, sisters, mother, father, grandparent, those kinds of people, you should make sure your providers are aware that you have a family history of some kind of clots. And when it's most important is going to be around times of surgery, trauma. Those things are always going to upregulate your clotting cascade. So it may warrant a different type of prophylaxis post-operatively so that you don't develop a clot afterwards. Smoking, for sure, we know, obesity, immobility, those are all things that are modifiable. You can stop smoking, you can lose weight, you can get active. You can't change your genetics though. So that's why making sure you have a good history before you have any kind of surgery. If you have a family history, now you have a history of it. So just make sure that whenever you're going to have any kind of procedure that's invasive, you let that provider know that you've had a clot, even if it was provoked.
And we were talking about flying and driving. There's also some seated exercises that you can do to get some blood flow moving, especially down in your legs. Can you talk about that at all? A couple of
Sure.
maybe seated exercises?
Yeah, so the calf pumps, or just step on the gas, keep pushing your foot down on the gas, pump those calves while you're sitting in the car or in that. Those are probably the best ones. Or just even bringing your knee up to your chest when you're in an airplane or in the car. You can do that. If you're driving, don't do that. But
Right.
if you're the passenger, you can do some leg exercises just to increase the circulation to those big vessels down in your legs.
Yeah, great, Diane. Thank you. Leslie?
Well, so one of the things Todd's been talking about lately is sleep apnea. And that apparently is a risk factor for blood clots also. Why is that? Is it
Oh, it's
oxygen
an
or?
upregulation of everything, including your circulatory system, and you can have some problems with hypotension and things like that when you have sleep apnea. So it's also another risk factor for developing atrial clots, because you can develop atrial fibrillation if you have sleep apnea.
No, I
So
know that.
that's one of the first things that we check for when someone is newly presenting with atrial fib is, do they have sleep apnea? So it has a wide variety of cardiovascular events that can happen when you have sleep apnea.
I would think also that just the uh, oxygen, is not flowing
I'll tell you, I was a little shocked yesterday when I got the diagnosis of severe sleep apnea,
I'm
and
sure.
I'm really glad I did the sleep test, the sleep study. And I think if people are having a hard time sleeping, that's recommended
Yeah.
because that's something you really want to know.
No, I thought it was a great thing for you to be bringing up. Okay. Okay, let's come back to what to expect after diagnosis. I know we kind of touched on the first 30 days, but recovery is different for everybody. And so if you can walk us through like what's typical during 0 to 30 days, 30 to 90, and then after 90 days, physically, emotionally, and medically, because I know a lot of us have also suffered on the emotional part as well. So walk us through those kind of timelines, 0 to 30, 30 to 90, and then 90 plus.
So during the first 30 days, it's expected that you're going to have some pain and swelling in the lower extremity if that's where your clot was. You should not continue to have chest pain. That should resolve pretty quickly once you're treated. And I think during the first 30 days, your body is getting used to the new medication. It's kind of the time where we see the most bleeds is during that first 30 days. So after 30 days, if you've made it through 30 days and haven't had a GI bleed, you're doing pretty good, because that's usually when we see it. Because for two reasons, you're on a higher dose of either the apixaban or the Xarelto, and then your body's getting used to it. These drugs are not going to make you bleed, though. They're going to make you bleed faster. So you have to have a hole somewhere. So if you have a gastric ulcer that's just kind of been laying around, and then you give it some anticoagulants, we will see more GI bleeds during the first 30 days typically than later on with the new drugs. That may not necessarily be true with warfarin. So as people's INRs go wacky and they may have a higher INR, they may get a GI bleed a little bit later. But it's kind of like a declaration. So we look during that first 30 days for GI bleeds and hematuria, which is blood in the urine. And I've had 3 men that presented. Now, it wasn't during the first 30 days, but they presented with hematuria and were diagnosed with bladder cancer.
Mm-hmm.
So that was before the DOACs. That was while they were just on warfarin. So, the drugs, having a clot is not a great thing for sure, but being on an anticoagulant can sometimes lead you down the path where you discover other things that need to be treated that you may not have known if you weren't on the anticoagulant. During day 30 to 60, life's becoming more normal. You're returning to your normal activities. We don't encourage you to go skydiving or horseback riding without a helmet. Or I know Todd rides his bike, but he wears full gear. So lifestyle changes for risky sports and things like that probably need to be made during that 30 to 60 days. Your leg should have gone back down. You can develop what's called post-thrombotic syndrome. So if you still have a painful swollen leg after 30 days, make sure you go back and see your provider and make sure that they do something to check and see if there's an extension of the clot or if there's anything else that can be done. There are procedures that can be done to help patients that have post-thrombotic syndrome. There's not a ton of organizations that offer them, but there is options for that. And then by 90 days, you should be back to full swing doing what you like to do. What we didn't touch on was the emotional part. So it's very, very normal to feel anxious and worried that you're going to die. This is not something to be taken lightly. But as time wears on and you get better, as long as you take your medicine, chances are very good that this clot is well controlled and you've caught it early. Unfortunately, for people that get a clot that they don't catch it early, those are the ones that typically. I can't say that I had a patient in the 22 years I was doing anticoagulation that died on anticoagulation because of another clot. They may have died because of bleeding, but they didn't form another clot. So paying attention that if you have any blood in your stool or urine, you seek immediate medical attention. If you're a postmenopausal woman and you have vaginal bleeding, that is not normal. Don't let a provider tell you that any of this type of bleeding is because you're on an anticoagulant. Remember what I said, the meds don't make you bleed. They make you bleed faster. You have a hole somewhere that shouldn't be bleeding. So just make sure you're your best advocate. If you have a doctor that tells you you're bleeding because you're on anticoagulation, you might want to seek another opinion.
Yeah, no, that's great advice. I just had this conversation with a patient recently where she's postmenopausal, she had vaginal bleeding. She was told by the doctor it was being caused by the anticoagulant, and she ended up actually having cervical cancer. And he was completely and totally wrong about that. So that's great advice. Talk to us though, for those of us that were put on anticoagulants, especially when the dose is really high, that are menstruating, that have their period. When should we be concerned about, very heavy period? Have that conversation with your doctor as well, because there's not enough discussion about this.
Oh, I've had women end up in the ICU that have bled while they're menstruating. So, and I've had to switch their anticoagulants. So for some reason, my women bled heavier while they were on Xarelto than when they were on apixaban. They did fine on apixaban, and there's no rhyme or reason to why, but that's what we did. So if normally if you're using tampons and you use, say, 6 a day, and now you're using 10 or 11, that's abnormal. If you're doubling the number of pads, or if you're lightheaded or dizzy, are you becoming severely anemic? So just kind of keep track. But I mean, it 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 will increase. Typically, most women will say that their periods are heavier when they're on anticoagulants. Not always, but a lot of women did. So I would say if you've gone, like if normally you're at 5 a day and now you're at 8 or 9, then you should talk to your OBGYN and say, hey, this is what's going on, and have them partner with your anticoagulation specialist to come up with the plan.
Is there any particular DOAC that causes heavier menstrual bleeding than another? Or are they pretty equal?
I was a heavy Xarelto user, but I will tell you that I had to switch more women from Xarelto to apixaban than apixaban to Xarelto. So I would say when I was dosing, the Xarelto, that it was probably more Xarelto than apixaban.
Okay. I really wish that clinicians would get out in front of this for women, because it is a very big deal for us. And there's just not enough information on that, what's normal, what's not normal, and just make people aware of it. Todd?
Yeah, there's a lot of gaslighting going on, and in the group, I hear from those patients all the time, and I can't even imagine how frustrating that is to have to battle that. and not get the information that they want and then be gaslit in the process.
On top of it. Yeah.
That's not fair. Let's move on to something else that's part of daily life. Being on a blood thinner can raise some questions about just normal lifestyle. And we touched on a little bit, but I think there's a lot of things we can still talk about here. First of all, Diane, and I'm going to throw a bunch of questions at you and we can revisit as we go along. Are there foods that people should totally avoid or just be careful with now that they've suffered a blood clot and now that they're on anticoagulation? Why do some anticoagulants need to be, oh, we already talked about why they need to be taken with food, so we're going to skip over that. We talked about Xarelto. Is there medicine you cannot take while you're on your anticoagulant? So what about like anti-inflammatory, NSAIDs? What about herbal supplements? A lot of people want to get into the natural herbal thing and start taking mega doses of stuff. How does that affect things, and is it wise to do so? The stress factor, we talked about anxiety. You know what? Sometimes people just want a glass of wine. Have a beer. Can you have alcohol while you're on your anticoagulant? And finally, what's safe when it comes to exercise and physical activity? I know we talked about me being active and other people being active and wearing your helmet. If there's anything else you can think of, you can throw in there. But start with the foods. Is there anything we should avoid or be really careful with?
The only one that you have to worry about is warfarin. If you're on warfarin, which very few patients are nowadays, but it would be your vitamin K containing foods, and just be consistent. Doesn't mean you can't have them or you can have a ton of them. You just have to be consistent. So if you want to eat them every day, about the same amount. And if you don't, with the DOACs, no. With medications, there are certain drugs that I touched on that can be inducers or inhibitors. So just make sure that you talk to your anticoagulation provider before you start any new prescription medications. There's drugs like rifampin and some of the the inducers, some of the seizure drugs can really speed up the metabolism of the drugs. So just make sure you're talking to your providers when you get a new prescription. And all they have to do is put it in. If they're on Epic, you just put them in and it's going to pop up and it's going to tell them if it's an inducer or inhibitor of the CYP3-450 system, which is in your liver. And that's where your drugs are mainly processed. Alcohol, everybody should have some if they want some, just in moderation. So I'm saying like have one glass of wine or one beer. That is not going to affect your oral anticoagulant. What it will affect if you drink too much is your ability to fall down and hurt yourself or get a head. You know, we always say if you fall and hit your head, you have to go to the emergency room because you can only accommodate a teaspoon of blood around your brain. So on anticoagulants, you can bleed a little bit faster if you put a hole in one of those blood vessels. So that's why I say, you know, especially with anxiety, and that if you want to go out and be social and don't feel like you're the oddball out and have a glass of wine, by all means do. That's my personal opinion.
I have to have a glass of beer. I mean, that's
Yeah.
just, I'm not the big wine guy, but I got to have a drink. It takes the edge off, right?
Right.
You want to live your life.
Yeah. You don't let it control you 100%. Sports, running, just make sure you wear if you fall and hit your head, whatever you're going to do, if there's a chance of you hitting your head is what we're worried about.
Yeah. And speaking of that, do you think it's a good idea that people wear a medical alert bracelet or some kind of an ID tag if they're on an anticoagulant? How do you feel about that?
I think they should. The DOACs are quick on, quick off, but if you don't know if a patient's on it and they need emergency surgery, you don't want to find out after you've cut.
Right. Okay. Thanks, Diane. Leslie?
For sure. And yes, I agree with your comment on alcohol. Sometimes it's just nice to have a glass of wine, or sometimes even two. Okay. Let's talk about getting pregnant after a blood clot, because we have a lot of women who write in about this. Some people think that they can't have children after having had a blood clot. Is pregnancy safe after a blood clot? I'm assuming you're going to say yes.
It's a dilemma is what it is, because pregnancy is a prothrombotic state. Your body is making more clot, getting ready to deliver a baby because you don't want to bleed to death when you birth a 9-pound baby. Um, Anticoagulation during pregnancy typically involves doing low molecular weight heparin or unfractionated heparin. None of the drugs are safe throughout the whole pregnancy. They've not been studied. There's no ongoing studies that I know of on the orals. So it is a dilemma. You will see a high risk OB if you've had a clot, but I would never say never. And, when I was early on, where all we had was warfarin, and the patient did not have a blood clot, she had a mechanical valve, but she wanted a baby so bad. And that was one of the scariest times of my career, is taking care of this patient with a mechanical mitral valve that wanted to get pregnant. And we had to manage her and do levels on her hep. She was on unfractionated or heparin part of the time and low molecular weight. But I would say it is not a no, but it's not without risk. And the risk is going to be highest during the postpartum period. So just be aware that after you deliver, you need to get right back on your oral medications. If you can do the orals, it depends on if you're breastfeeding or not. They don't know for sure. We know that some of it crosses into the breast milk, but we don't know how much. So typically that would entail staying on low molecular weight heparin for the first couple of months.
Okay. So I know you worked on this curriculum actually, women are at risk of a blood clot for up to 3 months postpartum. They should be aware of that. And also, if you've had a blood clot, you are more susceptible to another blood clot, obviously. Doesn't mean you can't get pregnant. A lot of people have had blood clots and gotten pregnant, but you should have your OBGYN and your hematologist and your anticoagulation expert involved in your plan, your protocol. So we really, really want to impress that upon women. Okay, I'm going to punch it back to you, Todd, for the last question, and then we've got a gazillion great questions from the group and also questions that have come in online as well.
We do. We have a lot of good Q&A. So we've asked you this before. We ask you this every pep talk that we do, Diane, because it's really important, and we love the messages that you give. So as someone who's helped so many people through their blood clot journey, what's one message you would share with those newly diagnosed today? What do you wish more patients knew about?
About being their own advocate. And one of my favorite sayings is, the only stupid question is the one you don't ask. So if you don't know and you want to know, don't let anybody make you feel dumb or stupid, because the only question that is stupid is the one you don't ask, because it could save your life. Be your own advocate and just be aware that you're not alone. I mean, this group, it does more for patients than any group I've ever been involved with. And it is evidenced by every time I do these talks, I'm impressed by the number of enrollees that attend. I've done webinars for different pharmaceutical companies, and we never get the turnout like this. I mean, this is near and dear to your heart and mind. So don't be afraid to ask questions and reach out. If you have a question or a concern, you can always send it to us.
Perfect.
Thank you. All right, Todd, you want to kick off with some of the questions?
Yeah. So this came in during registration. Can your blood pressure go really high when you get a blood clot? Also, is just 6 weeks of a blood thinning injection good enough?
Blood pressure typically is not a result of a blood clot. If you're extremely anxious about it, it can be because of the anxiety. 6 weeks of a shot is, I can't really say. I don't know what the circumstances were around your clot. Typically, if it was maybe a catheter, and like you had a PICC line and you had a clot, maybe 6 weeks is enough. But without knowing, those are about the only ones that I would treat for 6 weeks, would be if it was a catheter associated clot. Most of mine were a minimum of 3 to 6 months. I lean more towards 6. And like I said, we're leaning more and more towards long-term anticoagulation, even for provoked clots.
Yeah, that's a more talk to your doctor about
Yeah.
your individual case. Yeah. Leslie?
Yeah. I am a cancer patient. What kind of doctor should I be seeing with regard to blood clots?
Hemonc, your hematology oncology person should be involved with, if you're a cancer patient, you should have someone from oncology that's a hematologist as well involved so that they can decide when and if you need to change your course if your platelets drop too low. So typically cancer patients, I always encourage to get a hematologist that was a hem-onc person.
Okay, so let's play devil's advocate here for a little bit. So, cancer patient is dealing with cancer diagnosis, which is incredibly overwhelming to start with. A lot of times they don't get information about blood clots. It's really important that they have this because of the correlation between the two. You say to your doctor, I want to see a hematologist. The oncologist says, no, no, I've got you covered. You don't need a hematologist. What should the response be?
But I want to. Can you explain to me why you don't want me to see a hematologist? I would feel more comfortable dealing with a blood specialist since I have a blood clot.
Yeah, agree. So we really want people to self-advocate. It's hard. And it's particularly hard in these types of situations, but uh, you got to say, I want to see a hematologist, they're a specialist, or a hematologist oncologist, they're a specialist. Don't be shy about it.
Just remember, providers are humans, and you're going to have good providers, and you're going to have providers that aren't always good. You have good humans, and you have humans that aren't so good. So if you're not happy with the answer you get, do you have to stay with that provider?
Yeah,
I mean, be your, like I said, the only one that's going to advocate for you is you or your family.
yeah, for
Mhm.
sure. I fired my first hematologist, and now I love my hematologist. So that can be done also. And you're right, there's good and there's bad in everything. Todd?
Yeah, I fired a few doctors myself, but we do have to show them some grace. I mean, the knowledge that I've received
Absolutely.
from my providers is unbelievable. From the Q&A box, can APS develop over time, or are you born with APS?
It is an acquired disease, and you don't necessarily acquire it when you're born. It can develop over time. And just remember, it has to be tested twice, at least 6 weeks apart, with those blood tests being positive for you to have that diagnosis. And it shouldn't be done while you're on oral anticoagulants. So a lot of times you have to go on an injectable.
Okay, thank you.
Okay. Do compression socks prevent blood clots?
No, they increase blood return to the heart. So they decrease the likelihood of getting another clot and help with the swelling, but I wouldn't say they're a prevention. By pumping, well, I guess that's kind of a double-edged sword because if they continue to pump the blood back to the heart, maybe they do prevent it, but it's not something that is going to help once prevent a clot that's already there.
Okay. Thank you.
Compression sure helps my post-thrombotic syndrome. It helps with the
Correct.
swelling
It
and the pain. I
definitely
mean,
does.
that
Yeah.
is the reason I wear compression.
Right. And that's
Um,
why I still, and new patients, I always prescribe compression hose. Interestingly enough, all the studies that were done were with 30 to 40 millimeters of pressure. I have never had a
wow.
patient be able to do that.
Wow. Yeah,
So
that's
20,
strong.
20 millimeters is pretty tight, and that's typically what I would prescribe because I didn't want them wasting their money on compression hose that they weren't going to be able to
Yeah.
to use. And they were really expensive back in the day. Now that we've got Amazon, they're much cheaper.
Right, right. So, we we have a shortage of blood. We need to donate. And so many patients ask this question, but can I donate blood while I'm on an anticoagulant?
I saw that question and I don't know. Um, I
I
don't know
called
if
the
you
Red
can or
Cross
not.
and asked them, and they said only if you stop for a certain amount of time, but who's going to stop their
No.
anticoagulant just so
Yeah.
they can get blood? You can't do
I
that.
mean, I've never been asked that question, so I don't know.
Okay.
But I mean, if you called the Red Cross, yeah, for sure not then.
Yeah. Okay, Leslie?
Okay. Oops, sorry. I lost my place here. Okay. Uh, my blood clot was caused by hormonal birth control. Am I at risk of getting another clot even if I come off of my hormonal birth control?
Yes. Once you've clotted, you've declared. So it's considered a provoked clot. So your risk is never going to go back down to what the general population is, which is 2 to 3%.
Why is that?
Because you've declared. I mean, you've got some scar tissue now because you've had clot. And I don't know if there's a good answer to that. Why? I mean, just once you've clotted, you never go back to the way you were before. So we just
Mm.
know that provoked or unprovoked always are higher risk than someone that's never had a clot.
Okay. But again, if you're on your anticoagulation, taking your medicine, the risk is not zero, but it's pretty darn close.
Very close. I mean, what I'm saying is if you go off of your oral anticoagulant or your oral birth control and you're not on anticoagulation, your risk is going to be much higher still then. But if you're on the oral anticoagulant, your risk isn't any higher. I would say that's going to be, as long as you're on the anticoagulant, you're fine. Now, I've had patients that needed to stay on hormonal therapy because it was either that or they were going to kill their spouse. And so they had to stay on long-term anticoagulation because we knew that that was a provoking factor, just like, birth control. If someone's refusing to go off their oral contraceptives, it's against advice, but then we definitely make sure that they stay on their oral anticoagulant.
Hmm. Okay. Good advice.
Want to talk side effects from the anticoagulant real quick. So this question comes from some of our group members, and I got to tell you, Diane, it's like in the top 5 or 6 questions asked about side effects. But has anybody ever asked you about hair loss, about hair thinning while they're on their
Yes.
anticoagulant? Is that a direct relation, or why does that happen?
They don't know why it happens, but alopecia is the technical term, and it's common in all of the DOACs as well as warfarin.
Mm, that's that's very that's traumatic for people.
For some
And
people, it is.
yeah.
And that's what, talk to your anticoagulation provider sometimes. And I haven't stayed on with what there's certain shampoos now that help restore the hair growth. And one DOAC may be better than the other for the patient. So it may be switching to a different DOAC to see if you're on Eliquis, maybe Xarelto would be better, or vice versa.
And I also had a doctor tell me that it can happen with severe emotional trauma as well. That there's a
There's so
name
many
for it.
different things that
Yeah.
can cause it.
Yeah, yeah, that's too bad. Leslie?
Okay. So this is going to be, I don't know, we might have to duke this one out in the dark alley or something, but here we go.
Okay.
My hematologist didn't want to order any genetic testing for an unprovoked blood clot. What is the protocol for digging deeper?
So when
This is a
I was
great
treating
question.
just anticoagulated patients, if it was a female patient with recurrent fetal loss, we would dig deeper. If there was a strong family history, we would dig deeper. We would first make sure that the patients were up to date on all their cancer screenings. So have they, are they 45 and had a colonoscopy now, is gotten younger and younger and younger? Um, have they had their pap smears? Have they had mammograms? Has the PSA been checked? Those kinds of things. But again, if you're adamant and you're not getting the answer you want, seek medical attention someplace else then. If you need this to sleep at night to know one way or the other, go ask someone else.
And I appreciate that tremendously because so often we're told it's not going to change the way we treat you. And we understand that it may not change the way that you're being treated, but it's a horrible thing to live with, not knowing why something has happened to you
Hmm.
and to be dismissed. At least give patients the option if they want to dig deeper or not, as opposed to just being dismissed and say it's not going to change the way that you get treated. So thank
Absolutely.
you.
Right. It isn't going to change. And there's certain like thrombin deficiencies and things like that that are more serious if you have another family member, then maybe they need to be tested too so they don't have a clot.
Mhm.
So there are things that, but having that shared decision making discussion and talking to your provider and say, I need this so that I can sleep better at night. That I need to know if I'm in danger, or do I have something that my children might get, or that I have a sibling that
Yeah.
might have. Then typically I think if you can, and I suggest you put it down on paper before you go in, because people get nervous when they go in and talk to their providers, and just say, I have a couple questions. And if they say they don't want to test, say, well, these are the reasons why I'd like to be tested, and explain to them how you're feeling, because sometimes providers can be cold and not read the room and not see that you're uncomfortable not knowing what caused your clot.
Yeah. And I think there's a direct correlation between that and anxiety because you don't know why you got it. You're afraid that you're going to get another one and you don't have any answer as to why it happened to begin with. So giving people the option, I think is just really important. Okay, Todd?
So I had an acute massive pulmonary embolism in my right lung with wedge infarction on the 6th, or excuse me, on January 6th of this year. So just recently, still getting pains in the chest. Is this normal?
I would like to say it's not. They're, massive pulmonary embolism. I would say you should not still be having chest pain. It's been 2 months. So you may need to go back in and, see your provider, and they may need to do another angiogram and see what's going on, why you're still having chest pain. I would say 8 weeks out, it's not normal. Maybe up to 4 weeks, I would say. But by then, your body should have gotten a good amount of clot dissolved that's going to dissolve. So, are you infarcting that lung?
Sure. Okay, thank you. Leslie?
How long does it take for my blood clot to dissolve?
Sometimes it won't. Sometimes you'll grow tissue around it, and it's called endothelialized. So there'll be residual clot. Some patients will come back a week after they've had their pulmonary embolism and have a repeat scan, and it's gone. So there's no crystal ball with predicting. It just really depends on your little Miss Pac-Mans, how fast they work.
Okay, great. Todd, I think we should have one more question. It's 8:05. Everybody's been awesome. I know we can't get to everybody's question. Just to let everybody know, we are hopefully going to get Diane in the patient group. We have to get it all worked out, but we're going to try to get her in a couple hours a week, hopefully, hopefully starting in April, maybe, so that we can get more questions answered for folks, because you're just such a wealth of information. And with that, no pressure. Todd, I'll turn it back over to you.
Okay, one last question. So somebody's having horrible side effects on almost every anticoagulant that they've been on. They want to try like natural ways and remedies and supplements that'll just get rid of their clotting problem. Is that even possible?
No.
Thank you.
That's all we needed on that one.
I love that you are like this. Yes, no. It's so
No,
helpful.
I would not recommend it. If you've had a clot, using homeopathic or herbs to dissolve your clot, there's no evidence to support that. I would encourage you, if you're not tolerating the orals, to do low molecular weight heparin or something, and see if, some combination. And then, I mean, sometimes you have to go back to old fashioned warfarin. That was a
Right.
very well tolerated drug.
There are people still on that, been on it for 40 years, and it's doing them just fine.
Yeah,
Yeah.
absolutely.
Yeah.
All right, let's bring the exit poll questions back, and then we will let everybody go home. And Diane, thank you again for everything. So remember,
My
Diane,
pleasure.
for March, June, September, and December.
Okay, we've got 3 questions for you, so easy in and out here, and then I'll read the results. Did tonight's discussion help you understand your diagnosis better? Yes, no, not sure. Will tonight's discussion make you more informed to discuss your diagnosis with your doctor? Yes, no, not sure. And did tonight's discussion make you more confident understanding your anticoagulation treatment? Yes, no, not sure. And we'll get those results, and then we'll turn everybody loose for a Tuesday night.
This was awesome.
It always is. I love the quarterly navigating a new blood clot
Yeah.
diagnosis. It
I
always.
learned so much from you every single time you're on.
Mm-hmm. I'm
I'll
sure
talk to you
everybody else
later.
does too. Okay, here we go. Let me scroll up. Did tonight's discussion help you understand your diagnosis better? 88% said yes, 5% no, 7% not sure. Will tonight's discussion make you more informed to discuss your diagnosis with your doctor? 95% said yes, 5% no. And did tonight's discussion make you more confident understanding your anticoagulation treatment? 88% said yes, only 5% said no, 7% not sure. And that's it.
All right, awesome. Diane, thank you again. Todd, thank you.
Thank
And
you.
remember, it's Blood Clot Awareness Month, so we look forward to everybody supporting prevention, education, and awareness. We've got all kinds of great things going on, so come check out stoptheclot.org.
Yep. Thanks, everyone. Thanks, Diane.
Bye, guys.
Thanks.
Bye
See
bye.
y'all later.